Bismillah ar-Rahman ar-Rahim. Our case today, this patient preterm, 28 weeks gestation infant has been born. Chest x-ray and abdominal x-ray is taken at 4 hours of age. So A, you have to describe the x-ray finding. B, what is your diagnosis after you describe the x-ray finding? And third, what will you do next? First of all, you have to describe what is in the x-ray. First of all, you have to comment about the lines first. If you goes here, you will see here, this is the ATT. You see this is the ATT. Actually is very high. It's above the carina by 2 centimeters. So this ATT, you need to adjust this ATT into tracheal tube. You have to adjust it. This is the first thing. The second issue is here, if you look for this line, this is UEC or UVC. How I can differentiate between UEC and UVC? This is UAC. You see it's down, it's come down, then come up. You see it's come down, then it's come up. It's okay. This is the UEC. But unfortunately, this is malposition of the UEC. You see, it's reached to subclavian. It can reach to the subclavian artery. You see, can reach to subclavian artery. It's very deep, really is very, very, very deep. But in your mind, any malposition of the umbilical vessels or such UEC or UVC or something like that, you put in your mind the complication is can lead to arrhythmia or lead to pericardial tamponade and pneumopericardium. Any malposition of the umbilical vessel lead to arrhythmia, cardiac tamponade, and pericardial effusions or pneumopericardium. So this line, the UVC actually is very deep and you have to adjust it. You have to pull it down to the appropriate position, either in the low position or in the high positions. In the high position it will be 6 to 9 thoracic, or low position it will be in the L3. So this is, you have to correct the position of this UAC. The second issue is you have to comment about the lung, and we mentioned lung field and lung volume. Lung field and lung volume. If you see here the lung volume, you have to calculate it from down. If you see here, this is 12. You see there is 12, then 11, then 10, there is 9, there is 8, this is 7. This is decreased lung volume, and if you see here, this is air bronchogram. You see here air bronchogram, this is air bronchogram. You see this is air bronchogram. And also if you can see here, this is ground glass appearance. You call it pepper and salt sprinkling on the film. So what is the classic radiological finding of RDS or respiratory distress syndrome? 3. First of all, air bronchogram, then diffuse ground glass appearance, and third, decreased lung volume. What is the meaning of air bronchogram? This means the air present in the airway, surrounded by area of the air is not present, so it will give you pepper and salt appearance, and diffuse ground glass appearance, and decreased lung volume. So this is the 3 cardinal sign of the radiological finding of RDS: air bronchogram, and diffuse ground glass appearance, and decreased lung volume. So this is the description of the X-ray. This is case of respiratory distress syndrome. So the both lung field, diffuse ground glass appearance, and there is bilateral air bronchograms, and the intratracheal tube was high, and UEC appear to be somewhere close to right subclavian artery. So actually here, this is diagnosis is actually it's respiratory distress syndrome with incorrect placement of the UEC and ATT. You have to adjust it. What you will do next? So I will adjust the UEC is need to withdraw into the more appropriate positions, either in the high position or in the low position. The ATT also will need to insert it further. We need to push it down because it's very high. NGT should be inserted for intestine compression, because the stomach is actually is dilated. You have to ventilate this stomach or decompress the stomach or the intestine. So this patient have severe RDS. I have to insert or to give surfactant administration should be considered. Here, this is the most important paper guideline. We call it European Consensus Guideline in 2019. The very magic paper, magic paper. You have to print it down and keep it with you during you are taking on call in the NICU. I will try to summarize it in the few minutes. First of all, you have to treat this patient prenatal. This is the management of the RDS. Perinatal care, then delivery room stabilizations, this is called the NRP, and postnatal to be respiratory support and surfactant and supportive care. So the prenatal care, it will be 4 issues. The prenatal care, it will make it maximize this one. I will maximize this one first. We'll see. This is the prenatal care. The prenatal care, you first of all, any premature babies at risk of RDS should born in the center appropriate care for RDS and can deal with the RDS patient, and the mechanical ventilation is available. This is the first thing. Any baby at risk of RDS should be treated in the proper place, can manage such cases. If you cannot, you have to refer this patient intrauterine transfer to higher center or appropriate center can manage such cases or can deal with patient with RDS and the mechanical ventilation was available. This is the first thing. The second thing, actually, any premature deliveries need actually or corticosteroid if high risk or moderate risk. So I have to, any premature deliveries with high risk or moderate risk, you have to start dexamethasone, ticolytics, and magnesium sulfate. 3 medications. First of all, dexamethasone. Why we need antenatal dexamethasone? Because actually the Cochrane review proved it will decrease the risk of the RDS, also to improve the brain maturation, the neck and BDA and IVH and all of this, having short term and long term. But at least it will help for improve the lung maturations. The second medication you have to give it to the premature deliveries, the tocolytics. This is two benefit from the tocolytics. It will give time for effective management of the dexamethasone, and also it will be give time and safe transfer to higher center where appropriate to treat such cases or RDS. The third medication is magnesium sulfate, and we said this magnesium sulfate for impending premature deliveries. It will help for neurodevelopmental outcome or to improve the neurodevelopmental outcome. So any patient high risk for or premature babies high risk for RDS should transfer to center appropriate management for RDS and mechanical ventilation is available. The second, dexamethasone you have to give to improve the lung maturation. Tocolytics to help the dexamethasone to help for allow time for dexamethasone to work, and also give time for safe transfer to higher center or center can deal with RDS. And the third medication is magnesium sulfate. It will help for you have to give it for impending premature deliveries to improve the neurodevelopmental outcome. This is the 4 antenatal. Then we'll go for the delivery room stabilization. This is NRP. Just the baby will deliver. Just to inform the OB/GYN doctor, please delayed cord clamping. What is the meaning of delayed cord clamping? It will be 30 to 60 seconds, almost will be 1 minute, at least 1 minute. Why we need to do this practice, delayed cord clamping? This, if you delayed cord clamping, this means you are giving blood to the baby, so it will prevent a need for blood transfusion, prevent late anemia, and also you looks like you give volume expander, so this patient actually will decrease in need for the inotropes. It will decrease in need for inotropes. So this is the benefit from delayed cord clamping. The second issue you have after the baby delivered and the delayed cord clamping done, you have to take this patient and put it in the radiant warmer. Provide warmth to prevent avoid excessive heat, to prevent the heat loss, so to maintain the temperature. Either the premature babies, you can treat him with either to give him, to put him in plastic bag or radiant warmer, or warmed blankets, or warmed mattress. You can put it from down, either to put from up, from down, and you can put it hats. You plastic bag for hold the body, or provide warm from above, and mattress it will be warmed mattress from down. So anyhow you have to provide warmth for these patients to prevent the heat loss. So delayed cord clamping, then put him provide in the radiant warmer to provide and to stabilize the premature babies, especially the less than 28 weeks. Then after that, you assess this patient heart rate, oxygenation, and breathing. Check the breathing. The baby is breathing, but labored breathing and maintain temperature and saturation. You have to connect it immediately to CPAP if possible. If the patient tolerated, you put him in the CPAP. So this is the first action. You put him in CPAP if the baby is breathing, but labored breathing and heart rate and the oxygen saturation is maintained. If the baby actually if having cyanosis only and he maintain his heart rate and breathing, you have to give supplemental oxygen. If the baby apnea, gasping, or this is indication for post pressure ventilation. So indication post pressure ventilation, if the baby heart rate less than 100 and the baby is gasping or apneic, you have to give positive pressure ventilation. So you give positive pressure ventilation, you have to avoid excessive tidal volume while you are giving, and you have to connect the baby to pulse oximeter to monitor the heart rate and saturations. So, and you check the response for stabilization. Once you give positive pressure ventilation, you have to connect it to oxygen. How much oxygen you have to give for such babies? Any baby less than 28, I have to start at 30%. If the baby between 28 weeks to 31 weeks, I have to start it between 21 to 30%. This is the oxygen I have to give. How much the oxygen target oxygen saturation at the time? It will be 80% or more within 5 minutes. You call it oxygen target saturation. You know, in the first minute it will be 60 to 65. In 5 minutes it will be 80 or above within the 5 minutes. This is our oxygen target saturations, and you have to titrate the oxygen requirement based on the target oxygen saturations. So I give him positive pressure ventilations. This patient is still the baby require few minutes of positive pressure ventilation and still is not having spontaneous breathing. So this is indication to intubate the patient. This is you have to intubate this patient. Once you intubate this patient, actually this is the indication for intubation. Either the patient not respond to above measures, the positive pressure ventilation, and require for few minutes, or the baby from the start Silverman score for this or Downey score is more than 6 and having severe RDS, such the baby is retracting, chest retraction, and the high oxygen requirement. So this is indication to intubate this patient and to connect to pulse oximeter. And you have to put in your mind, once you intubate this patient, you have to put pulse oximeter and cardiac electrodes. So this is the NRP. This is NRP, how to stabilize the patient in the delivery room. How to stabilize the patient in the delivery room. Delayed cord clamping. The second, you provide the warmth, then check the heart rate, oxygenation, and breathing. If the baby is breathing well, you have to put in the CPAP. If the baby is not breathing, you have to give positive pressure ventilation. How much oxygen you give during positive pressure ventilation depends on the gestation age. The gestation age less than 28 weeks, you have to give 30%. If the baby more than 28 to 31 weeks, I have to give just only 21 to 30%. Then I titrate the oxygen based on the target oxygen saturation. Our target oxygen saturation at the 5 minutes, it will be 80%. If the patient is not respond to positive pressure ventilation and require more positive pressure ventilation for few minutes, this indicate, and the baby having severe RDS, this is indication to intubate the patients. Then after you intubate the patient, actually you have to transfer to NICU. In NICU here, actually with respiratory support and surfactant, so this is the time of surfactant. Surfactant will be animal derived surfactant. When to give the surfactant? If once you intubate the patients or having severe RDS, oxygen requirement more than 30%, and the patient on CPAP 6 centimeter water, so I have to give the first dose of surfactant. First dose of surfactant, once you patient intubate, you have to give the surfactant, or the patient require more than 30% of oxygen, so you have to give the first dose of surfactant. What is the indication for second dose of surfactant? If there is ongoing evidence of RDS. What is the indication for second dose of surfactant? Or if there is ongoing evidence of RDS. So this is the surfactant indications. How to administer this surfactant? You have to be non-invasive. How to give it? To call it LISA. If you look here for this, is called LISA. This is the method non-invasive, called less invasive surfactant administration. Less invasive surfactant administration. This is the non-invasive surfactant. It's if the patient is tolerated and the patient it was in CPAP, and then the patient was in CPAP and oxygen requirement is increased, or the baby distressed, at the time you have to give the surfactant. We call it less invasive surfactant administration, and should be the patient tolerate this, and also you have expert person to give the surfactant by this technique. To call it LISA or MIST, minimal invasive surfactant administration. So I will give non-invasive by non-invasive way the surfactant. If it's difficult or the baby is not tolerate, so this is the time to intubate this patient. But once you intubate this patient, actually you have to give, we call it ensure technique. Intubate, give surfactant, then extubate. Extubate to CPAP or high flow nasal or non-invasive immediately following the surfactant, and after that it will depend on the individualized babies and depend on the tolerability of such a patient, because sometimes you will put him in CPAP and you give surfactant by LISA and the patient still not tolerate this procedures or not tolerate this practice, so you have to intubate. Once you intubate the patient, you have give surfactant and extubate. Also they call it ensure technique. Might is not also tolerate this practice or not tolerate this technique. If not tolerate this technique, you have to intubate and keep it in the mechanical ventilation. If you keep him in the mechanical ventilation, you have to keep in short time. You have to keep in short time as possible, and if you can, and try to avoid the hyperoxia and hypocapnia and volume trauma. And you have actually, once you intubate this patient and put him in mechanical ventilation, the best mode to put him is volume target ventilation. You can put it BC, pressure control, assist control with VG or volume control, or you can put it from the start volume target ventilation. And saturation alarm, you have to put it 89 to 95%. The accepted oxygen saturation 90 to 94, and the alarm it will be less 1 or more than 1. It will be 89 to 95. So you have to give surfactant, the first dose of surfactant, if the patient once intubated or oxygen requirement more than 30%. And indication for second dose of surfactant, it will be if there is ongoing evidence of RDS. You give the surfactant. Then how to administer the surfactant? The best and the preferable non-invasive, and should the patient tolerate these issues, and also you have expert person to do this. You have two conditions. The most important, to give LISA or less invasive surfactant, the patient can tolerate this technique, and you have expert person to can give this or administrate the surfactant by this way, or call it less invasive LISA or MIST, minimal invasive surfactant administration. You try to avoid intubation, so you have to give it by non-invasive way if the baby tolerate and you have person expert to do this. If you don't have and the patient is not tolerate this technique, you have to intubate this patient. But once you intubate this patient, you have to extubate immediately. We call it ensure technique. Intubate, surfactant, then extubate to CPAP or high flow or non-invasive. Also, again, if the patient not tolerate this technique, and you depend on individualization, depend on your patient can tolerate this one or not. So if he can tolerate, well and good. If not tolerate, you have to intubate and keep it in the mechanical ventilation. But if you will put him in mechanical ventilation, it should be in short time. And the best modalities for mechanical ventilation at that time, it will be volume target ventilation, and you have to set the alarm for oxygen saturation. It will be 89 to 95, or the accepted saturation 90 to 94. So if you will bottom intubation, so you bottom intubate and mechanical intubate him and mechanical ventilation, and you have to give it in short time. But if the baby actually it's severe RDS and you have to ventilate for long period of time, actually, so you have to give medications to facilitate the extubation. What medication? It will help you to facilitate the extubation if the baby require ventilation for more than 1 week or 2 weeks. First of all, you have to give methylhexancine or caffeine. It will help for minimize in need for mechanical ventilation. Also, another benefit for the caffeine or methylhexancine, it will prevent apnea prematurity and to facilitate, and also it will help to prevent extubation failure. The second medications to give it if the baby require mechanical ventilation after 1 and 2 weeks, you have to give systemic steroid. We call it DART protocol. We call it dexamethasone meta-analysis randomized control trial. Randomized control trial. This indicated should be 5 condition. You have to rule out if there is any sepsis, because this is the cause of deterioration. You have to rule out if there is BDA, the patient is cannot extubate because the BDA or because the sepsis, or you have to rule out cytomegalovirus. You have to rule out candidal infections, and you have to take consent from the parents before you start it, because it's liable for poor neurodevelopmental outcome or the cerebral palsy or cognitive function. It will be affected. So you have to start DART protocol. This short course or long course. Long course actually you can take maybe 10 days to facilitate extubation, and should be severe RDS. Not for all RDS, should be severe RDS. And severe RDS, this mean actually this patient or early, call it early BBD, sign of early BBD, you can see it in the X-ray, or oxygen requirement was increased. The patient, it was in 30s, in 60s and 80s, and the baby is long mechanical ventilation, stay for the mechanical ventilation for 1 week or 2 weeks, and the oxygen requirement was increased. So oxygen dependent, ventilation dependent. So at the time you can decide to give DART, call it dexamethasone meta-analysis randomized control trial. Short course or long course. Long course, it will be 10 days. It will facilitate the extubation of this patient actually, and you have to start caffeine. Also, it will facilitate for or minimize the need for ventilation, prevent apnea prematurity, and prevent failure of extubations. It's okay now, caffeine, and you have to set the target oxygen saturation. Our target oxygen saturation 90 to 94, but the alarm, it will be 1 down and 1 above. It will be 89 to 95. This is the alarm. This is the respiratory support and surfactant administrations. Regarding the supportive care, it will be 2T, temperature, you have to maintain the temperature, and TPN, and 2F, feeding and fluid, and 3B, you have for monitoring the blood pressure, monitoring blood culture, and pain score. blood pressure, blood culture, and pain score. So this is the supportive care. Supportive care, the temperature, you have to take care or to maintain the body temperature between or at 36.5 to 37.5 all the time, at all the times. And this is the temperature, then the TBN. You have to start the TBN, amino acid and the lipid and dextrose and all of this, and you started with 70 to 80 ml per kg per day, and for most of the baby, and you have to restrict sodium during the early transitional period. So you have to maintain the temperature and TBN. Then we'll go for the fluid and feeding. Feeding, you have to start the enteral feeding with mother milk, should be started on day 1 of the baby if the baby is stable. So the feeding can start from day 1. From day 1 if the patient is stable and the ABM or express breast milk is available to give it at that time. So you have to maintain the temperature, the TBN, the feeding and the fluid, and we'll go for the monitoring. They have to monitor the blood culture and started antibiotic ampicillin and gentamicin. You have to take the septic up and start antibiotic ampicillin gentamicin. And also regarding to you have to regular aiming to maintain normal tissue perfusion also, if necessary, for using inotropes and hemoglobin should be maintained and acceptable at acceptable range. So I have to monitor the blood culture, take septic cup, start the antibiotic ampicillin gentamicin. I have to monitor the blood pressure and check the tissue perfusion, and should the capillary refill time it will be less than 2 seconds to maintain the tissue perfusion and prevent lactic acidosis. So at the time, if the baby having capillary refill more than 2 seconds or poor perfusion, I have to start inotropes or volume expander based on the condition of the patient, and have to keep the hemoglobin in the normal level, in acceptable level also. And you have to monitor the pain score, and each unit should adopt protocol for the pain management, and you have to monitor the pain and discomfort and consideration to given non-pharmacological method of maintaining the pain, and also to judge the use of the opiate for more invasive procedures. So I have to monitor the blood culture, I have to monitor the blood pressure and pain score, and based on the pain score, shall I give non-pharmacological management or pharmacological management? Non-pharmacological management like sucrose, and you give it just to the baby, or pharmacological management, you have to give the opiate at that time. So this is the call it supportive treatment. Call it supportive treatment. Supportive treatment 2T. You have to maintain the temperature and you start it TBN, and 2F, the feeding and fluid, and the fluid will be 70 to 80 ml per kg per day, and feeding should start from the first day of life, and if the patient is stable and the ABM or express breast milk is available. And 3B, you have to monitor the blood culture and take septic workup and start the antibiotic and ampicillin gentamicin, and you have to monitor the blood pressure and the tissue perfusion. If the tissue perfusion is affected or capillary refill time is more than 2 seconds, you have to start the volume expander first, or you can give inotropes if needed, and you maintain the hemoglobin in the acceptable range. And the third B, the pain score, you have to monitor the pain score, and you have to adopt a protocol for the pain score adjust based on the pain score if the patient is need non-pharmacological management or pharmacological management based on the pain score. So the non-pharmacological management like saccharose or pharmacological management like opiate. By this way, actually we finish now the management of the RDS. You have to print this paper and keep it with you for your practical issues, and to help you during the managing RDS baby in your ICU. شكرا. سلام عليكم.